Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Bayer.
Hi, and welcome back to our podcast on preventive cardiology and the cardiovascular risk continuum, where our theme throughout the series has been know your risk and act early. So I'm Dr. Michael Blaha from the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. And so far in this 6-part series, we've had 5 episodes so far, leading into our 6th episode today. And that first one was about primordial prevention and early risk factors. And episode 2 was about the calcium score. Episode 3 was about carotid ultrasound and vascular age. And episode 4 tried to bring this home to how we make decisions for patients about lifestyle and medications based on risk factors and imaging. And we talked about some cases in episode 5 and how we might change our management with, for example, a risk assessment of risk, specifically with imaging. And here in episode 6, we're going to bring it home and talk about personalizing cardiovascular prevention from methods to meaning, where the hook for this episode is not all patients are the same. So, why should their prevention strategies not be personalized too? So, again, joining me is my colleague and friend, Dr. Amar Jory, who's professor of medicine and cardiology at Queen's University and the founding editor of the POCUS Journal, the Point of Care Ultrasound Journal. So, Amar, thanks so much for joining us again for episode 6.
My pleasure. Wonderful to be here. Thanks, Michael.
Yeah, such a fun series. So, I want to kind of bring the whole 6-part episode into a summary here and talk about one of the overarching themes, which is the limitations of risk scores, right? I think you and I both believe that risk scores have a role. They're an important starting point, but they have limitations. So tell me what you think are the good things about risk scores and what are some of the limitations?
Yeah, great question. So I liked your introductory statement that not all patients are the same. We've been using population averages to guide individual decisions, right? And personalization is an approach where we try to align biology, behavior, and risk to ultimately have better outcomes for that person in front of us. So it's the idea of moving beyond conventional risk scores. We still cannot throw out risk scores. They're really helpful. The good thing about them is they're inexpensive to do and they're scalable, providing population level calibration. But there are some downsides. They're often derived from historical cohorts and they may miss subclinical disease. So these scores may not be well aligned to looking for and predicting what happens if there's subclinical disease. And so they're poor at individual level precision and may underestimate risk in certain populations, such as women or people of color or different ethnicities and ages as well. So they're good for populations, but too blunt for individuals. And so that's why looking at additional tools such as imaging can be very helpful. And these tools are not competing with our conventional risk scores, but they're part of the armamentarium, this larger toolkit approach, whether you're using calcium scoring or carotid ultrasound, and bringing this all together to provide a more personalized risk approach for the patient in front of you.
Yeah, I like so much what you said in episode 3, of course, where we're talking about making this tangible for the patient. You mentioned that patients don't understand necessarily the probabilities that we talk about with risk scores. You have a 5% risk in 10 years, where the response is, well, is that high or is that low? Does that mean that there's a 95% chance that I won't have an event? Why would I take a medication then? This helps make it more tangible. By nature, imaging of an individual makes risk more personalized. Even showing a patient the results of imaging can be actionable for the patient, can reinforce the decision and maybe adherence to a therapy.
Exactly. We move beyond a statistic to the presence of disease or not based upon visualization or detection.
That's right. The great thing about these modalities we've talked about, the calcium score and the carotid ultrasound, is we can actually quantify the plaque burden too. Not just you have some plaque, but how much plaque you have, and is that more or less than we expected? Is that going to change our decision? So let's compare real quick the two modalities, calcium scoring and carotid ultrasound.
Calcium scoring, excellent, excellent prognostic validation. Very good for ruling out risk. For example, if you have a calcium score of 0, carotid may have advantages in earlier detection because it may pick up non-calcified plaque as well. And there may be some behavioral advantages if the carotid ultrasound can directly show plaque right away to the patient. And there may be some point of care scalability. So it's a little bit more accessible than a CT based modality in some settings. So the right test really depends upon the patient that you're dealing with and the clinical question and the resources that are available in the setting that you're operating.
Yeah, yeah, that makes sense. So something that comes up from time to time. Well, is this approach cost effective? I mean, isn't it just better just to use risk scores, even if they're maybe not perfect? But I think there's a case to be made that when you treat high risk patients more aggressively and treat low risk patients maybe less aggressively, and you prioritize shared decision making, there's an inherent value there. So, how would you describe cost effectiveness or efficiency of prevention care when using a joint risk factor and imaging paradigm?
Yeah, I really liked what you said there because you mentioned it's not just about putting patients and categorizing them at higher risk, right? There might be some patients that are low risk. And that is, I think, the idea of precision medicine and teasing out who needs more and who needs less. If outcomes are reduced from primary prevention, then in the long run, costs would be lower to our system on the whole. Risk scores are the most inexpensive, but if they're missing subclinical disease and these patients are having outcomes later on, then we're actually not saving on costs by using and relying only on risk scores. So, who could it be more effective for us to apply imaging scores on? It could be the intermediate risk group. So, it's not the low risk patients that we're looking at doing additional imaging or the high risk patients. It's this middle gray area that we feel would be of highest yield. And certainly, calcium scoring does have a little bit of higher upfront cost. There is some CT infrastructure cost that's required. In comparison, carotid ultrasound can be considered lower cost, especially if it's portable and repeatable and can be integrated into clinical workflows. So it depends on the scalability of that modality within that region that you're working in and how that can enhance the quality of care being provided and screening provided at the community level. So those are some of the things to think about when we're thinking about costs in the short term and long term costs that might be saved.
That's a great point. I want to think about the interprofessional care team too here, because of course we can't bring our most intensive diet interventions and exercise interventions, maybe our rehab specialists to everyone. We have to be selective of where we focus our attention. We want to focus that attention on the highest risk patients. So let's talk about and how we would maybe use our prevention resources differently if we had a patient with no plaque, let's say, or a patient who had extensive early plaque.
Right. It's that idea of moving away from treating all intermediate risk patients the same way. Now, if we're able to further refine that intermediate risk gray category and find out who is lower risk and focus our resources towards the patients that are slightly higher risk. So those are the patients that I would be encouraging to think about statin, more aggressive lifestyle modification, getting them connected with a pharmacist to help with their adherence. And so it does really tease out the intermediate risk group patients that are lower risk versus those that are higher risk and should have resources. And that's what personalized medicine means, as opposed to treating that whole category the same way.
That's a great point. So let's talk about a rapid fire case. 50-year-old man, family history, average risk factors otherwise, comes in to see you and says, I got a family history. I don't think I have any other risk factors. My diet and exercise are okay. What's my risk? It's hard to answer that question without having some other tools.
Yeah. So there are different tools that you can use. There are several online scores that you can use, such as the Prevent score or the Framingham Risk score. Here in Canada, we do use the Framingham Risk score. And so we would plug in this person's age, and you mentioned family history, which is important. They're more on the low side of risk. Their Framingham risk score would probably come out to maybe around 10. I would have a conversation with them to really understand, was this early coronary artery disease? What is the family risk? And I would probably do an LDL at this age and determine whether there's an indication for statin. Now, if their LDL level is high, I would proceed to treating. If the LDL is moderately high, this is where I feel that further stratification might be important. So it depends on your practice, on how worried they are about their family history. You could send them for a calcium score that would also have a reassuring effect if it's low, or if you are able to do a POCUS at the bedside and just take a quick look to see if there's any plaques.
Yeah. Okay. Let's say you did both. Let's say the calcium score was several hundred, and let's say the carotid plaque score was 2 or 3. In other words, there was at least 2 or 3 segments involved with plaque. So this person has advanced subclinical atherosclerosis. How would that change your approach to this patient? And specifically, what would you do differently in this patient, in this scenario, as opposed to if the carotids looked great and the calcium score was 0?
Right. I would actually be putting this patient into a higher risk category. And I would be a little bit more worried about them. Your risk will change depending on what approaches you might undertake. So, how tight do we need to control this patient's blood pressure moving forward? How tightly do we have to reduce their LDL to target? And how aggressively do we have to suggest diet and exercise changes into this patient? And there's different things that you can do, and you really have to talk to the patient about, would they focus on one over the other. So they might just say, you know what, just give me a pill. I just want to take the medications and get everything under control. Some people may have the perspective that, give me a chance to modify my diet, give me a chance to do some exercise. I can get rid of that plaque and start getting my risk factors under control. So that's what you're going to offer, different approaches to a patient, especially since they're asymptomatic and it's subclinical disease. And this is what we mean by shared decision making. When you have different options and different approaches, and you try to personalize those approaches to what the patient wants to do and what they can do and what they will adhere to.
Right. This patient with the high calcium score and the carotid plaque score will get a little bit of the all the above, right? We'll probably discuss an aspirin, probably discuss an aggressive LDL goal and aggressive lifestyle, which would be quite different Presumably, if the calcium score or the carotid plaque was zero, we probably would not recommend an aspirin. Maybe the LDL goal is more lenient and maybe foundational lifestyle approaches. But I always wonder what some of our provider colleagues out there who aren't using imaging do in this case. I guess they might just say, well, your LDL is not that bad. Maybe work on some diet and exercise. But to me, it misses the nuance. It misses the possibility we might have a very aggressive early case of atherosclerosis, or we might have someone who actually doesn't have any atherosclerosis at all. So I guess to our listeners out there, thinking about knowing your risk and acting early, to know your risk and act early, you need to know your numbers. And in some cases, we need to know your plaque burden. And that's going to drive decisions on everything from aspirin to statins to LDL goals to blood pressure goals and all in between. And of course, our new cholesterol guidelines from the USA now state specifically set the LDL goal based on, if you have it, the calcium score, or presumably another atherosclerosis imaging test. So, this is a great summary of what we've talked about in this podcast. So, let me pass it back to Dr. Jory and say, any other practice pearls for integrating a personalized approach into prevention? Let's say you're our listeners out there, a primary care doctor or someone who's starting a new prevention practice and wants to do the right thing and practice at the cutting edge. What are some pearls for that provider?
Yeah. So before I mention those pearls, you asked what are our colleagues doing when they're not using imaging? And I think our colleagues are bringing exceptional clinical nuance and intuition and experience and working very hard. Unfortunately, what's happening is that a lot of patients are still having outcomes. Patients are coming in with first time heart attacks and strokes at an earlier and earlier age. And the conventional risk scores are not picking things up. We know that these patients are not getting primary preventive therapy. And we do have the medications and approaches that work. You mentioned the fact that imaging is moving up in the guidelines, the new lipid guidelines, and are endorsing calcium scoring now, class one in many settings. Carotid ultrasound is often class 2B or selectively recommended, but the evidence is evolving. So I suspect it's going to move up to class one at some point as well. And myself and other colleagues are doing randomized controlled trials to try to show the evidence that this is important and makes a difference. I'll end with the pearls that you had requested. So, my thoughts are that using imaging in the gray zone is important. So, it's not the obvious cases, it's the area where we want more certainty. And think of calcium scoring and carotid ultrasound as complementary tools. And think about using these tools when there's going to be an action afterward. So it's not just about the diagnostics, but what are you going to change afterwards? And don't forget that in some patients, showing them the disease process may help them and may improve adherence and may motivate them. That's been shown in the literature. And then finally, the concept of interprofessional teams and making sure we bring in our pharmacology colleagues and nursing colleagues because primary prevention is hard, especially when the disease is subclinical. You don't have the same urgency. And so that's why bringing in our interprofessional colleagues and building these networks and these teams is helpful for improving the care that our patients receive. So ultimately, personalized prevention is about aligning the right test to the right patient and the right intervention at the right time.
That's perfect. Thank you so much for this discussion. Once again, thank you for listening to this 6-part series on preventive cardiology and the cardiac risk continuum, where we're breaking down the traditional barriers between primary and secondary prevention and encouraging all of us to know our risk and act early. Thank you again for listening.
Thanks, Michael. It was a pleasure.